Well, for more on this, I've now been joined by Dr. Alexander Chinedu Nnadozie, who is a senior medical officer with the Gwarimpa General Hospital in Nigeria's capital, Abuja. Very warm welcome to the Arise interview.
Thank you very much.
I'm sure you are as worried as UNAIDS, the World Health Organization, as a medical practitioner, that the total concentration right now is on COVID-19 against other viruses like the HIV/AIDS, which is as deadly as the COVID-19.
Yes, I'm as worried, maybe even more worried because of the peculiar place we find ourselves, because we are in that sub-Saharan Africa they're talking about. And if you look at the period of the lockdown, the strict lockdown in Abuja, in Lagos, in Ogun State, a lot of people could not access their HIV clinics. A lot of HIV patients who are living with it and who are comfortable with the drugs they are getting, they couldn't access. Even if they wanted to go, they didn't have the transportation to go because there was a lockdown. Now, if we look at that period and people not taking their drugs for that long, you know, in the heart, what we call highly active antiretroviral therapy, they give to the HIV patients. There is the first line, there is the second line. Now, those who are on the first line and then they miss their drugs for that long, they may end up in failure of the first line, and they may need to be tried on the second line. And this is where we may have a number of deaths in months to come as a result of people missing their drugs. For now, Nigeria, for example, especially in Abuja where I stay, we have up to 1 year supply, if not more.
In your stores, not to your patients already?
No, in the stores. So I'm talking about that lacuna. That time they couldn't access it.
Yeah.
Because today in my facility is HIV clinic.
Yeah.
And there were a number of them, about 100 of them were seen today in the clinic. But at that time when they couldn't come. And then in so many other remote places where they may not be able to move to access these drugs, there could be a problem with that period. And then if COVID-19 continues, even what we have in store may run out.
And when that runs out, there's crisis.
There may be crisis because these drugs are gotten from the international communities, those that support the system. So if there is a problem with international travels and movement of goods and all that and drugs, there could be crisis.
Now, let's look at a simplified way of, in a situation like this. They say desperate situations requires desperate measures or actions. Why is it that we don't have a data system that could have helped, during that very serious lockdown for 5 weeks, could have helped to reach out to your patients, those who would have run out of their drugs?
Yeah, that brings me back to the kind of system we run, the kind of health system we run, the primary, the secondary, and the tertiary. It was in December that the NMA and the Commonwealth Medical Association had this health summit and talked about universal health coverage vigorously. Because the people that come to where I work, for example, which is in Life Camp, they come from very far places. Okay, and in these places, they're supposed to be primary health centers where they stay, and they're supposed to easily access these drugs from their primary health centers, very close to them, so that at times of lockdown, you just walk, everybody knows you, you're registered, your data is there, you just go there and you collect your drugs, and you won't have to go this far. Now, the places where people get drugs from, there's data, they have collection. That is how they know, as at last year, we were able to get to 1.4 prevalence rate of HIV in Nigeria.
And what is the death ratio?
As at that,
is it reducing or is it spiking?
It is reducing. It is reducing with the treatment, with the support from international organization, with more acceptance, because people used to live in denial. A lot of people kind of accept now and do what you tell them to do.
Yeah, that they can contract this the disease.
That the disease is real in the first place.
Yes, and still live another 40,
normal
50,
life.
60 years normal life.
Exactly. So the death rate is reducing. Even though when we look at the 1.4 we're talking about, does it mean that we have more death than we have new cases? Is that why we have 1.4? But that is by the way. So we have the data of those who are accepting drugs at different places, accessing drugs at different places to put together. But when people are focusing on COVID-19, when the whole country was focusing on COVID-19, there was no such plan. What about things like this that depend on the system running? what will happen to them if we take these measures for COVID-19. So there was no such plan. And then we were just in the hospital. We had very few patients to attend to at that period of the lockdown, even the HIV patients that normally come for their drugs. But since the lockdown was eased, they started coming, but we fear that we may have an increase in death in our hands.
Okay, I wanted us to talk more because of the kind of figure that the UNAIDS and WHO just reeled out. Let us look at mitigating factors really to avert the kind of fears. 2020, 2021, you're going to have no less than 500,000 deaths. That's a lot of people in sub-Saharan Africa, Nigeria inclusive. What kind of mitigating factors should government, and its agencies be doing? This coronavirus is not going to go for a long time or very quickly. So what are the measures to be put in place now? You mentioned one, yes, using the primary health centers in their community or maybe wards or local governments.
Yes. Thank you. When WHO gives out this kind of estimate, it is not to scare anybody. It's so that governments can actually do something.
To wake up and choose responsibility.
And if government does, that will not happen. The 500,000 will not happen. So this is what they want to do. They want to give you the estimate, what they have calculated, they will extrapolated, so that you do something about it. So, and part of what is going to be done about it is what you people are doing now by talking about it, so that government will be stimulated. Okay, one of the major ways we fear is what we call vertical transmission, which is from mother to child. Okay, and the mothers eventually probably dying if they're not on their drug and leaving orphan children who are exposed. So if you go to most of the hospitals, they are trying to decongest and say antenatal clinics, okay, don't come if you don't have problems, okay, maybe call on phone, come at this interval, increasing the interval at which they have to come. But care should be taken for those on what we call PMTCT, okay, prevention of mother to child transmission of the HIV. Care should be taken about those ones to make sure that their supply does not run dry, okay, so that we keep them healthy, so that they have children who don't have HIV and they themselves don't die and leaving the children. So PMTCTC should be focused on, even while there's a lot of focus on COVID-19, there should be a focus to avert what WHO is saying. There should be a lot of focus on mother-to-child prevention of HIV. Okay, they should galvanize efforts with the primary health centers, like we've talked about, and then look at the stores. We have about a whole year supply. Okay, where are the places that will have this whole year supply? Is it just the cities? I don't know about the rural communities, the far places where the figures of HIV and AIDS are really coming out from. Do they have the supplies like the cities have? Are some other parts of the country going to be willing to release their own supplies to those that are lacking? So this is what we should look at now, and to see if international communities can move drugs even when there is international, there's a ban on international travels. If drugs can move instead, because these are for survival. So these are things we need to look at on time, not when 2021 comes and we don't have supply, then we start running around and start discussing and start bringing out funds that could have come out earlier and solve problems.
Yeah. Are you okay, apart from what the UNAIDS and WHO raised about, the HIV virus and disease and the rest, how about malaria, diphtheria, diarrhea, et al.?
Yeah. So that is the issue. We are really going to have a little shift in our population at the end of all this. And it's not just from COVID-19. We have about 150 deaths from COVID-19. Earlier this year, we have way more than that from Lassa fever, okay, which is just rounding off now. And then malaria is a constant killer. And with the lockdown in places, giving palliatives will solve food problem, okay, but what about medical problems? There are those that will die from their diabetes. There are those that may die from complications from hypertension and all that if they do not access the hospitals. And people are scared of going to the hospitals. Even
some of the hospitals are even shut down, the private hospitals. They don't want to open, they're scared.
Yeah, of course. People are scared because if you do not, if you can, I have colleagues in private hospitals who have resigned. If you cannot provide the necessary PPEs, people don't want to work. And then if you can't afford it, you may just have to shut down because you will just make medical workers get infected with the virus. So it's very important that we look at all these. There are associations that are dealing with maybe hypertension, malaria, all those subgroups in the Federal Ministry of Health should also be activated even more than they used to be at this time to prevent a situation where there will be a big shift in our population at the end of 2020, 2021.
A big shift that is going to be reduced or is going to rise?
No, I'm talking about reduction. By the time we get death from COVID-19, death from malaria, death from diarrhea, death from everything, and it's going to really affect the country, both in the workforce and health-wise in all families.
What kind of stories are you hearing from your member colleagues in the Nigerian Medical Association in Kano, in Yobe, in Gombe, and some other places about the COVID-19 and the deaths?
Yeah,
the resignations, for example, are they only in Abuja or it cuts across?
The resignation I talked about was one in Abuja and one somewhere else, not Abuja.
Okay.
But then there is this panic.
You align yourself with the Pharmaceutical Society of Nigeria and their submission there. Should Nigeria be going to Madagascar for herbal medicine when we have more than enough fauna in this country to make various herbal medications?
I'm happy that the Pharmaceutical Society of Nigeria is saying this. I'm very happy because there are a lot of, sometimes we question when pharmacists and pharmaceutical companies come to present their drugs, most of them foreign, to us and to see if we can use them for some of our treatments. And we say, where are your researches? And they show us foreign researches. And we ask, where are your local researches? And they talk about the companies are foreign, and then because of funds, they don't want to come and do researches here. So I know that there's a problem with financing researches locally in this country because these companies need to be funded. Okay, and now they worry that because any drug you're using to treat COVID-19 now is experimentally, because nothing has been approved, nothing has been tested long enough to be sure that it is safe. So even if you're getting the COVID organics from Madagascar, it is on experimental basis, and you should actually get consent from the patient before.
About remdesivir.
Yeah, even the remdesivir is a drug used for something else.
For Ebola.
Okay.
But they think it is efficacious enough to be used for COVID-19.
So yes, all of them are being tried. There's no
experimental
drug,
chloroquine is experimental and the rest.
Exactly. So if you're going to experiment on these things, then why not look locally also at what are people. I know we're looking for quick fixes because we're looking at an emergency situation, like we don't want people to die. Okay, Madagascar has 0 death. Can we just get what they have? Well, I understand federal government in trying to go fast, but at the same time, while you're doing that, maybe get the COVID organics and come and test it. But while you're doing that, you should look down. Look here, what people are doing here.
There's a monastery in Irua, in Edo State, that seems to be championing herbal remedies for certain ailments in Nigeria. I know the Federal Ministry of Health and the Alternative Medicine Department is already putting on trial a cough mixture, COVID mix or so, with NAFDAC and the rest. What more can you tell us about herbal efficacies in Nigeria? You've experienced that with patients and the rest.
I believe that the Creator or nature has arranged a people with the cure in their own environments. One of the schools of thought that believe that. So that you need to look at your environment to get a cure for what is wrong with you. For example, if you look at people who have sickle cell anemia, now it's more in Africa. Okay?
And very prevalent too in southern Nigeria.
Exactly.
And there is supposed to have been a herbal cure developed from University of Ife, then University of Ife, now Bafemi Awolowo University.
Yeah, but the point I'm trying to bring out from there is those who are carriers, those who are AS, they have this resistance to malaria, which is commoner in Africa. So this has been nature's way of keeping us safe from malaria. And that is why a lot of them had survived and then marry each other and produce a lot of excess. So you see that nature had planned, God had planned, okay, for making people survive some certain ailments, which means in your environment might be so many things that can help your illnesses. So it's a matter of picking them out. I worry about the herbal things people buy here and there and take.
On the roads,
yes,
you're talking about?
And even people who say they trust it, who are selling it. Because we see a lot of people come down with renal failures, with chronic liver diseases and what have you, because these things have not really been tested. I take paracetamol, I take 500 or 1,000 milligrams of paracetamol. I'm sure of what I'm taking, how much of it I'm taking.
That is if it is not fake.
That is if it is not fake.
But I mean, in the good old days, I'm sure your parents would have told you, your grandparents would have told you about the efficacy of dongoyaro in treating malaria. And it's like,
yes, but so, how much of it should I drink? Somebody should be able to calculate. Somebody should be able to do an experiment. How much of dongoyaro should a 70 kg man take if he has malaria? So these are the things we need to do with our organics. There should be research. They should allow the pharmaceutical researchers to do what they need to do, okay, and give us cure from our own environment. If we stop importing drugs, or if we reduce importation of drugs by half, we'll be saving a lot of money. It might not be immediate, but COVID-19 should teach us to look back home, okay? Keep buying what you're buying, okay, but then start working so that in a few years, everybody will be surprised how you arrived where you are.
Good. Orthodox practitioners in Nigeria, a lot of people say you make it difficult, you know, for other professional health workers like the herbal practitioners or the traditional medicine practitioners, because you always dismiss their products and, you know, their skills and say, oh, it's not scientific. And they tell you that, look, this is what they've been living with from centuries past again. Is there a new synergy now between the orthodox practitioner and the herbal medicine experts?
We want the synergy to be there, but like what we dismiss a lot of what they claim from what I have told you, we need to see. I told you that people come to present drugs and we say we need to see local research. So we need to see local research and then we will accept it, because we even have patients and relatives who we need to give the best of care.
And do you extend this synergy to NIPRID, for example, the Nigerian Institute of Pharmaceutical Development and Research? Do you extend it to the Pharmaceutical Society of Nigeria? Because the medical doctors in Nigeria and the pharmacists are kind of rivals. You don't find the pharmacists heading the Ministry of Health. They say, no, you cannot do that. Why? It's the same process you go for in training.
Yeah, well, at that level, it's politics to get to the head of. But if we get the drugs to treat our patients and it's working, we'll use it.
Because, of course, it's the pharmacist that is going to produce, you know, you do your prescription and the rest, and they do the dispensing, and they know the dosage and what have you.
And they make the drugs. We as doctors, we don't make drugs.
What are your fears about these spiking pandemic in Nigeria? I mean, the COVID-19 in Nigeria.
Thank you very much for this question. There is ignorance and there is the fear of stigmatization. I had a patient whom we heard talking on phone and saying if they find out or if they test me and I'm positive for COVID-19, I might be stigmatized at work. And I was so shocked, because why would an educated person fear stigmatization for what you did not cause for yourself? Or even if you cause it for yourself, why should there be stigma?
Why should there be stigma? I'm sure would continue to interrogate such issues and enlighten the public more that there shouldn't be stigma. Thanks so very much, Dr. Alex Nnadozie, as a senior medical officer with the Gwarimpa General Hospital, for coming on the Arise interview.
My pleasure.
Well, that's it for this edition of the Arise interview. Do join us again tomorrow from me and the entire team here in Abuja. Goodbye and thanks for watching.